Great. Welcome, everybody. Thanks for joining us from all over the world tonight. We just saw someone joining from Australia. I'm Brian Lewis, president of KidneyCAN. Really appreciate you all taking time out of your day or evening, wherever you are, to listen in and hear from a couple of experts. Welcome to Looking Back and Looking Forward. It's part of our town hall series. If you don't get to watch or can't watch through the whole program tonight, we'll be on YouTube in the next couple of days. And we couldn't do this without the support of our partners, and we appreciate ASI Exelixis. We also thank Genentech and Merck for their sponsorship of tonight. So let's get going here. Happy New Year, everybody, belatedly. I especially want to thank Dr. Raina McKay for joining us. She's a medical oncologist out at UC San Diego in California. Great place to be this time of year and all times of the year out in San Diego. Thank you, Dr. McKay, for joining us.
Of course, pleasure to be here.
Great, thank you. Dr. Hans Hammers is also joining us tonight. Dr. Hammers is at the UT, University of Texas Southwestern in Dallas. Dr. Hammers, we appreciate you being here. Thank you for joining us.
My pleasure. Thank you so much.
Great. Well, we're going to let Dr. McKay kick us off by taking a look back at 2022. It's in the rearview mirror, but I think we learned a few things as we're trying as a community to accelerate cures. So Dr. McKay, I'm turning it over to you, and then we'll come back with some questions, folks, and then we'll have Dr. Hammers, and then we'll open it up to across the country. So take it away, Dr. McKay.
Wonderful. Thank you so much, Brian, and thank you all for taking the time to join us this afternoon or evening or whatever time it is, wherever you're located at. So we're going to be looking back at what 2022 had to offer for kidney cancer progress, and it's really been an exciting year, and I think really nice to kind of reflect back on lots of progress that has been made. So I want to just showcase to everybody the tremendous progress that has really happened over the last, decade plus with regards to treatment options that have populated the landscape for patients with kidney cancer. And as you know, we start with the targeted therapy era in 2005, and every couple years or so, there's an approval of, one or two drugs, during the TKI era. We see in 2015 a real shift in the options that are becoming available for patients with the approvals of checkpoint inhibitors for the first time for patients with kidney cancer. That's when nivolumab first entered into the clinic, and any checkpoint inhibitor was approved for kidney cancer. We see the approvals of cabozantinib and lenvatinib, and these are sort of next generation VEGF targeting agents that, in addition to targeting VEGF, really help overcome resistance. Cabozantinib targets another protein called c-Met, and lenvatinib targets another protein called FGFR. And then what's highlighted here in yellow are the approvals in the adjuvant setting. So for people that are at high risk of recurrence, but don't really have any evidence of disease after surgery, we see the first approval of sunitinib. And then things really start to change in 2018, where the way we treat kidney cancer just is totally flipped, and we no longer are using frontline sunitinib, but are now using immunotherapy combinations. And we see the approval of nivo-ipi, Pemaxi, avulimab-axi, nivo-cabo, lenvatinib, pembrolizumab. So lots of new frontline combinations getting approved between 2018 and 2021. And then at the tail end of 2021, we see the approval of belzutifan for VHL disease. We see the approval of tivozanib, and also now the first checkpoint inhibitor for adjuvant therapy. There haven't been any new approvals in 2022, but there's been a lot of great data that have been presented over the last year of different, perioperative strategies and strategies for treating the disease in the frontline and recurrent setting. But you can see my plot is getting pretty crunched here on the end because we're having lots of approvals, particularly in 2021 was a very busy year. So I wanted to highlight sort of key studies that were reported in 2022. And these are large most of these are large studies that kind of warrant us kind of stepping back and taking a look at the data. So we're going to highlight the data about perioperative therapy from Checkmate 914, Emotion 010, and Prosper, and put that into context with regards to the current immunotherapy strategies in the adjuvant setting. We'll talk about the frontline data where we're beginning to investigate triple therapy with Cosmic 313. We'll talk about Pivot and CBM 588, which is a probiotic and had some intriguing data in the frontline setting. And lastly, we'll talk about some big data that got presented for non-clear cell RCC. So first I'll highlight the perioperative studies. So there was a handful of perioperative studies, very large trials that reported out in 2022. Checkmate 914 looked at the combination of Nivo/Ipi post-surgery for a 6-month period in patients that were high risk of having disease recurrence. Emotion 010 looked at a drug called atezolizumab, which is a type of immunotherapy in the post-operative setting. And Prosper looked at perioperative treatment with nivolumab. And while all of these studies were in fact negative for various reasons or another, probably in part related to patient selection, I think probably drove a lot of what we saw. The drug itself, and also with Prosper, I think one of the issues was there was a lot of opportunities for patients to kind of not actually receive the nivolumab that they were intended to receive in the way that the trial was designed. While these trials were negative, the Keynote 564 data really still stands strong. We saw updated data from this study at the beginning of 2022 at GU ASCO last year. And we continue to see with longer follow-up a significant benefit with regards to disease-free survival. And while the overall survival data is immature, there's a trend, a continued trend of potential benefit with regards to overall survival data, but this is, still maturing. So I think the fact that pembrolizumab is available as a potential option in the post-operative setting is really a positive thing for patients. I think a lot of times, patients have their kidneys resected and they're told they may have, stage 3 cancer with X risk of recurrence. And, prior to the approval of pembrolizumab, there was really nothing that we would be able to do for these individuals other than just expectantly watch them over time with serial imaging. But now there is the possibility of considering pembrolizumab in select patients who are at high risk of recurrence, understanding the risks and benefits of that therapy. So I think this is definitely progress. Dr. Hammers will talk about some other adjuvant studies that are likely in development in this context, but a lot of perioperative studies that we had been eagerly awaiting in 2022 to report out. So now in the frontline setting, this is for patients with newly diagnosed metastatic disease. We saw some interesting data being presented from Cosmic 313. Cosmic 313 was a study that looked at triple therapy. So looked at the combination of nivolumab, ipilimumab, and cabozantinib versus Nivo/Ipi placebo. And you may ask, well, why would we want to look at triple therapy? Why would we want to do that? And the reason why that is the combination of Nivo/Ipi, while it's an excellent combination and is associated with long-term durability in a subset of patients, probably 1 in 5 patients who get this regimen just don't respond. And while the combination of Nivo/Cabo is, associated with, great upfront response rates, we still are lacking data on durability. And so this study is really looking at trying to investigate, does the addition of a TKI in the frontline setting to an immunotherapy backbone improve outcomes? The trial was in fact a positive trial. It did demonstrate that there was an improvement in progression-free survival, but there's still a lot of data to be unfolded about the safety, toxicity, the impact on quality of life, and of course, overall survival. So while the trial was in fact positive, I think it definitely was, this regimen was definitely associated with more toxicity. And so we need to understand, who are the individuals that are getting toxicity? How can we better optimize the regimen? Who would potentially benefit from such a strategy? And is there any benefit with regards to overall survival? The Pivot 09 study looked at pegylated interleukin-2. There's this long name drug that's going to be abbreviated BEMPEG here, plus nivolumab versus a TKI. And while there was a lot of enthusiasm about pegylated IL-2, if you all recall, IL-2 is how we used to treat kidney cancer in the 1990s before we actually had really good treatments for this disease. The pegylated version of IL-2 allows for sort of more safer administration, and this regimen was administered sort of on an outpatient basis. But unfortunately, this study was negative. This data were reported at ESMO this past year. And the last trial that I highlighted is a trial that looked at CBN 588. And there was some very provocative data that were presented this year in this early phase study. CBN 588 is a type of probiotic that is given to augment the microbiome within an individual's kind of gut flora. And this drug was given in combination with nivo-ipi versus just being used, just nivo-ipi by itself. And it was a positive trial in that there was a very strong signal that the combination resulted in improved, a signal of potentially improved efficacy. This was a very small study, still very early days. And I think the study team is working to kind of think of how to move this to the next level, but provocative nonetheless. So lastly, I'm going to highlight on the non-clear cell studies that were presented in 2002. And specifically, I'll highlight the data from Keynote B61. As we know, individuals who have non-clear cell disease truly represent an unmet need, as a lot of large phase 3 trials exclude patients who have non-clear cell histologies. So we need to continue to move the field forward as researchers and investigators to make sure that the standard of care is improving for patients with non-clear cell disease, and we're better understanding the disease biology so we can better tailor therapy. This study looked at the combination of lenvatinib plus pembrolizumab for patients with non-clear cell histologies. And it while it was a single-arm trial, it was comparing to historic controls. And the combination resulted in an impressive response rate, almost 50%, 47.6%, with this combination when we look at the total study population. And while you can see the response rates for the patients that have chromophobe histology was low, the response rates for all the other tumor histologies, including papillary, unclassified, translocation, was greater than 50%. So that's really, compelling data. This is, again, not a randomized study, but provides rationale for use of this regimen for non-clear cell disease. So the take-home message is that adjuvant pembrolizumab remains the only adjuvant immunotherapy approved in RCC. It is available for individuals who are at high risk of recurrence after a nephrectomy. Frontline studies testing triple therapy with nivo-ipi plus cabo demonstrated initial positive results, but we're going to need further follow-up to understand how that's going to impact the standard of care in the future. And combination immunotherapy with TKIs are now being tested for non-clear cell disease and have demonstrated initial efficacy in some single-arm studies that have been done for patients with rare histologies. So I'll turn it over for questions.
Hey, great. Thank you, Raina. Appreciate that. Appreciate the insights and looking back into 2022. There's a lot going on, a lot to stay on top of, a lot of new language, new terminology there, new drug names, et cetera, to try to keep track of, especially with triplets coming on. I think we have one of our first questions. I think Lisa is standing by. If we can pull Lisa up here. I think Lisa, I'm not sure if your microphone might be on. There you go. I think you can go ahead. I'll turn it over to you, Lisa.
Okay, so my question is, what advances have been made toward biomarkers to help determine what type of treatment a patient should receive? IO versus TKI or some combination?
That's an excellent, excellent question. So I think that probably some of the most compelling data with regards to biomarkers that has recently emerged has been trying to understand the gene signatures of different types of kidney cancer tumors. And what we're learning is that there are some gene signatures that seem to be more responsive to TKI-based therapies, and there are some gene signatures that seem more responsive to immunotherapy-based treatments. The most robust data that we have to date comes from a study that looked at actually atezolizumab plus bevacizumab, which is a regimen that we don't actually use in clinical practice, but this study provided a wealth of data. There was over 600 patients that were enrolled, and the study team had collected their nephrectomy specimens and various specimens from metastatic biopsies and did very extensive comprehensive genomic sequencing of all of those tumors. And they were able to kind of cluster each of the tumors into these one of 7 buckets. And depending on the bucket that tumor was classified as, we saw a different response to a pure TKI regimen versus an immunotherapy regimen. And I'm not sure if Dr. Hammers is going to touch on it, but there's actually a phase 2 study that's currently being conducted by Vanderbilt with Dr. Rini that's actually looking at trying to strategize whether somebody gets IO-IO or IO-VEGF based off of the type of biomarker that they have. So our hope in the future is that we will be moving into a more biomarker selected strategy, but we're still not there yet.
Thank you, Lisa, and thank you, Dr. McKay. Dr. McKay, I want to bring Dr. Hammers up on screen, but before I let you go, we got a question in from the chat regarding the microbiome and the clinical trial that came out. Are you able to maybe give us a little flavor of that? Where that's heading, and then maybe we can ask another follow-up question when you both are on at the end.
Yeah, so this trial was actually conducted by the City of Hope team, by Dr. Monty Powell, and they had a collaborator at their institution that had been working with this agent, I believe out of Japan, and they were really keen on studying this drug in kidney cancer patients to see if we can augment. The primary endpoint of the trial was actually augmenting the tumor or augmenting the gut microbiota. And it did seem that there seemed to be a specific microbiotic signature that seemed to kind of correlate with better responses to immunotherapy versus not from some of the initial data that were presented actually at the KCRS meeting this past year. So I think this is very provocative. I'm certainly recommending for my patients to take a probiotic when they're taking their immunotherapy, as certainly this data evolves.
All right. We'll come back to this. I'm sure there are going to be some other questions. Thank you for the looking back at 2022. We look forward to you being a part of the community in 23. But we also have Dr. Hans Hammers from the UT Southwestern. Dr. Hammers, I'm going to jump off here and let you take over.
Hey, thank you so much, Brian. Ran a fantastic job. So we have a lot of things to talk about. Again, this is looking forward. So I'm not a prophet. I cannot tell you what's going to work eventually or not, but I will try to give you my best guesses. So if you think about the hallmarks of cancer, there are several areas that we like to target in kidney cancer. Certainly one of the main avenues for treatment is certainly, the immune suppressive effects of cancer, meaning the ability to evade immune destruction. We know a lot about agents that target the vasculature. As you know, classic chemotherapy doesn't really play a role. And then there's some efforts at like deregulating cellular metabolism. So the HIF2 inhibitors would fall in that range. We tried other metabolomics inhibitors, but they were unfortunately unsuccessful. And also we are moving into potential ways to resist cell death, maybe revisiting actually some cytotoxic agents and radiation therapy. So let's talk about the largest group that we are known to be employing for kidney cancer. So these are the angiogenesis inhibitors, the blood vessel inhibitors, that typically pills that target these pathways. And they are, very similar to each other. They have similar groups of side effects, if you will. And then there are some small flavor differences, if you will. And that sometimes helps us to recommend one over the other. And certainly they have evolved in combinations with immunotherapy. But there are some newer agents in development. I would say the agent that I would shout out here would be XL092. This is now being developed in combination with immune inhibitors and other combinations. Essentially, it's a follow-up molecule to cabozantinib. Cabozantinib is a great drug. I love to use it, but it has a long half-life. So this one has a shorter half-life. I think makes it probably easier to manage side effects and hopefully less liver toxicity and better combinability. That's one of the issues with cabozantinib that we saw, at least in the triple combination. And there are other pathways that actually affect angiogenesis, but actually I would say maybe even general aggressiveness of kidney cancer. That's the AXL pathway. Some agents actually target this to some degree. So cabozantinib at very high doses may actually target the AXL pathway in certain ways. Essentially, there's a receptor called AXL, and the Gas6 is kind of like the ligand. And then there are these molecules. One is called AVB500 that can kind of like prevent the interaction of the signaling molecule and kind of like taking some aggressiveness factor away. Actually, very well tolerated as a single agent, and in combination with cabozantinib, for example, showed some very interesting activity and is moving into the first line with cabozantinib and nivolumab. Again, maybe less enhancing immunotherapy, but probably enhancing the anti-angiogenic effect, maybe the aggressiveness effect of renal cell carcinoma. I think the next class of drug that's really going to be, if you will, the third leg, I think in kidney cancer are going to be the HIF2 inhibitors. So HIF stands for hypoxia-inducible factor 2. It is a transcription factor. And what that means, it's a protein that when it's abundant, likes to go into the nucleus and kind of like reprograms the cell. It's really turning on survival factors and preparing the cell essentially to survive under unusual circumstances. So it's really upregulated when normal cells don't see oxygen, and the sensor for oxygen is typically lost in clear cell kidney cancer. It comes up to very high levels, goes in the nucleus, and prepares these cells, although they do see oxygen, for survival and making them more aggressive. And that's one of the main drivers of the biology and behavior of clear cell kidney cancer. It really explains how kidney cancer thinks, in particular clear cell kidney cancer. And so there are small molecules developed, and I would say what's really stunning is how well they are tolerated. So there are very specific inhibitors of how these proteins come together and go to the nucleus. And I would say it's one of the few pills, if you will, where patients have to think about what the side effects are. Anemia is very common, can be managed, but it's a very, very unique molecule. Again, not yet available for metastatic sporadic kidney cancer patients, but it's being available. It's available and approved for genetic syndrome like von Hippel-Lindau. So there are other agents in the group that's in development. So belzutifan, which is from Merck, is not the only one. Niking Therapeutics has a small molecule. There are also efforts at maybe using, kind of like DNA pieces, if you will, that kind of like downregulate these molecules in the cell within kind of like a DNA RNA approach. And there's a molecule from Arrowhead, which would be an injection. And there's less efficacy than with a pill, and there's some interesting toxicities that were observed. So we have to see how that goes in general terms. But I think this clearly opened up the door for HIF2 inhibitors. And I think that's the next leg to watch that's going to come to the standard of care. Immune checkpoint inhibitors, as Rainer mentioned, it's the PD-1 inhibitors and the CTLA-4 inhibitor ipilimumab. Classic autoimmune side effects. You take 2 breaks off the immune system. You let the dogs out, if you will. Hopefully they go after the cancer, but they can also go after you. And so autoimmune side effects are the flavor of the day for these side effects, but you can get durable responses, as Rainer was saying. So that is certainly, I would say, the arm that we are most excited about at this time. The other immune checkpoints LAG3, for example, was positive in melanoma and is now being revisited in renal cell carcinoma. It's been around for quite some time, actually. So it's really more, I would say, an incremental effect, but measurable, at least in melanoma. We will see what the role is going to be in renal cell carcinoma patients. The other agents, and so again, if I don't mention it, don't be disappointed. I think they're not good targets. There are too many to really mention. I just pick out one that I think is quite interesting. It's an ILT2, ILT4 inhibitor. It's kind of like a myeloid immune checkpoint. So we had some disappointments there. It's currently developed in, not with this one, but with other similar agents. It's currently being developed in head, neck, lung, and actually renal cell carcinoma, where this particular target is highly overexpressed. And the word on the street is there's some interesting data. So we will see where this goes. CTLA-4 is a very unusual target. It's not well understood. I think PD-1 inhibition has been very straightforward, but CTLA-4 is one where really, I would say the effect is probably highly dependent on what antibody is being used and how it potentially engages with CTLA-4, the target, and how it's being recycled in the cell. And there are some newer agents out there that actually show activity in disease where we never see activity. So classic cold colorectal cancer, so not the one that has these hypermutations, but the one that's classic and cold. Typically, immune checkpoints play zero role in that disease, and they do see, in combination with PD-1, a 24% response rate, which is really exciting. So that's being revisited now. Also in renal cell carcinoma studies are coming, and other diseases. Might be a little bit more toxic in certain ways, but certainly an improvement over what we've been using for years. I do think that's possible. Cytokines, this is something that I grew up with when I had my formative years at Hopkins. We did quite some high-dose IL-2. Again, you had to treat a lot of patients to see the few durable responders who can easily be cured if they do really, really well. Again, small numbers, less than 10% of patients, unfortunately. And you saw a clinical trial that Raina mentioned that failed, which was a pegylated form of IL-2, meaning you could use a slower dose, was kind of like circulating slowly in the body, was supposed to decrease some of the side effects, but it really wasn't active, unfortunately. And so those trials were negative. But there are kind of like synthetic IL-2 variants that are now coming up. And one of these, for example, is nimbalukin. And my colleague Ulrika Bei-Champagne from Michigan, she has done some work with that in the phase 1 study. So it's a very interesting molecule, certainly shows single agent activity. And hopefully this is going to be developed in kidney cancer. The study, I'm not sure where that is going to go, but we put some patients on it. I think there was some interest, is interleukin 27. And that is also an aggressiveness factor to cells and an immune suppressive factor. And there was a small molecule that kind of like depletes the interleukin 27. There were responses, for example, in lung cancer, there was some modest activity in renal cell carcinoma. And I think a small company, they're developing this first in lung cancer. So we'll see where this is going to go. There are many other molecules that are being targeted. One of the other immune suppressive mechanisms is the adenosine pathway, like a breakdown product in the tumor microenvironment, and their adenosine receptors, when they're engaged on immune cells, they will actually suppress the immune cells actually quite effectively. And so there are small molecules and antibodies that are being developed to interfere with it, but this particular pathway. And so I want to give a shout out to actually Katie Beckerman at Vanderbilt, who runs a triplet trial with Nivo-Ipi, actually through the Kidney Cancer Research Consortium that some of you may know is being supported by the Department of Defense. And that is actually just opening this trial. I think one that is hopefully one to be watched and we are actually quite excited about. CAR T cells, I do think, have arrived for testing in solid tumors. This is a particularly difficult topic in solid tumors because the tumor microenvironment is much more immune suppressive than in leukemia. You essentially have to wipe out a whole organ tissue, if you will, without causing too much side effects in other organs. But there are some interesting cell surface molecules in renal cell carcinoma, and one of them is called CD70, and there are allogeneic CAR T cells that are currently in development, like from Allogene and CRISPR Therapeutics, with actually some interesting activity reported at a recent meeting, and there might be a biomarker approach to this. Interestingly, CD7 is not only expressed in clear cell, but also in actually a reasonable percentage in papillary renal cell carcinoma. So this is certainly something to be watched, and the companies may actually take some of the information that they have, go back to the toolbox, and maybe retool these cells. Talked about triple therapies, Cosmic 313. Even for me, who is not that scared of autoimmune side effects, I would say it was a touch too toxic for broad use. I do think there are more combinable agents that don't cause as much liver toxicity as we saw with Cosmic 313. This, I do think, a frontline trial that has probably has a good chance to have impact, really, how we treat patients up front. So it really builds on lenvatinib pembrolizumab, which is a very active PD-1 TKI combination, and then either adds belzutifan, the HIF-2 inhibitor, as a triple therapeutic, or adds Merck's own CTLA-4 inhibitor to the mix. So I do think it's an interesting trial for patients who are newly diagnosed and are looking for an upfront clinical trial. Radiation therapy is also something that is being revisited. Nowadays, we can take antibodies that may have failed in clinical development, such as girentuximab, that targets CA9 in the adjuvant setting, was a negative trial, but it's a beautiful marker for clear cell kidney cancer, and you can stick kind of like radioactive molecules to these antibodies and deliver them. My colleague, Dr. Jonish at MD Anderson, will have a trial open. Hopefully, this will also be something we can run through the clinical trial consortium. But there are also other approaches, not just radiation. I think ADCs, these antibody drug conjugates, might find their way back into renal cell carcinoma. These are approaches that are actually quite effective in breast cancer. That is a more chemotherapy sensitive disease. And some companies feel they may have now some better poisons, if you will, that even kidney cancer cells will have some difficulties dealing with. So some of these molecules are going to come back into the clinical development in renal cell carcinoma. So with that, I would say I would stop my presentation and open up with questions, do my best together with Raina to see what we can do to answer them.
Hey, Dr. Havers, thank you very much. Really appreciate that. We're getting a couple of questions in from some of the folks in the rarer subtypes. And one of them, in sort of summary, is, with the limited options that there are right now for chromophobe, based on all the available information that you have, what's showing the most promise, or could you give some advice around that, or some ideas, some thoughts?
Yeah, and I will love to hear from Raina as well to take a step at this. So it's a chromophobe, to me, is probably one of the more challenging subsets, no doubt about it. We don't really have a great handle at it. There's some data, again, small data sets. It's not really that common. As a chromophobe, like, for example, lenvatinib, everolimus seems to be quite effective for the particular combination. Unfortunately, immunotherapy itself is not commonly effective in that disease. So I would say, if you use immunotherapy, probably you really want to use it in combination with immune checkpoint inhibitors. So that's sometimes what I offer patients as well. So it's a real challenge. Cabozantinib, you use TKIs. Raina, what are your thoughts?
No, I completely agree. It's a total challenge. I definitely think that for those individuals that have non-clear cell histology, I really am trying to profile those tumors as best as I can, get genetic testing on them, see if there's any sort of targetable alteration. I do find that, the TOR inhibitors, actually combination TOR inhibitor strategies, tend to be beneficial for the chromophobe RCCs. And I know there's actually a large grant, I think, currently ongoing, specifically targeting research studies in chromophobe RCCs. So it continues to be an unmet need, but I think precision medicine strategies may potentially provide some insight into how better to target these tumors.
Great. Well, thank you. And I appreciate that. And we're going to try to get to as many questions as we can. I know we got a limited amount of time, and we got 5 people I know that are standing by to pop up here and ask some questions. So I might have to be a little bit rude to cut people off to keep us on track. So first one up is our own Meryl Uranga. Meryl, you want to come up, and I'm going to jump away for a second.
Yeah. Hi, Dr. Hammers. Yeah, it is. Wow. This is so amazing, both of you. Thank you so much for this information. It is just, there's just so much to think about, and it's so hopeful, and just appreciate the quality of this presentation so much. Are there any new drugs or combinations that are close to FDA approval in 2023? That's my question.
I can tell you, I'm sure you probably know. I mean, I think the next kid on the block for probably pan approval is probably belzutifan. So the large phase 3 has completed accrual. The data has been maturing. I don't know when the data is going to be released, but I think if I had to predict what would be the next drug to be approved, it would probably be that one for sporadic RCC.
Yeah, I 100% agree. It's a third leg. It's palpable. It's here. We know it works. To be honest with you, it's surprising why we have such a struggle to get it off label for patients, to be honest with you. I think insurance companies should not really have this barrier. I think if patients run out of options, 25% response rates roughly across pre-treated patients is a really good number, and it's extremely well tolerated. So yeah, I think it's about time. I'm waiting for it. I'm praying for it. So it needs to come.
Great. Thank you, Meryl. Appreciate that. Our next up is from Ohio, Tracy Miller. Come on up.
Hi, thanks everybody. Thanks to both of the doctors for your presentation. We really appreciate your time this evening. My question is for Dr. Hammers. Can you talk about any new immune checkpoint inhibitors that are in development currently? Thank you.
Yeah, thank you so much, Tracy. Yeah, I mentioned that on the one slide a little bit. It's so we always glance and look at other diseases and see what might be coming up. So I think LAG3, to be honest with you, it's been around when I was even at Hopkins, the trial with LAG3. So it's been in development for a long time, took a little while. It's probably because it's not like one of the big effects that we wanted to see, but it's an incremental effect and measurable, and clearly something that was worth doing in melanoma. So I think that's going to be revisited. I think that's the most, I would say, established but there are many other trials. HLA-2, there are trials with the myeloid in the myeloid compartment. So just because I didn't mention them, please don't take it as it's not a good target. There are too many to mention. I could literally fill a whole screen in 2 hours talking about all the different targets. But I think for people who are looking, look what's available, see what's available with regards to clinical trial in your area, or what people are starting to talk about, and see what's there.
Thank you.
Well, thank you, Tracy. Appreciate that. Next up, I believe we have from Massachusetts, maybe Chuck Straven. Chuck, come on.
Hey, Brian. Thank you very much. Dr. Hammers, Dr. McKay, thank you for your time tonight. I guess I'd classify this question under the out-of-the-box innovation scenario. And I guess at a high level, are there any new targeted drugs, whether it's drugs like TKIs, or are there whole new classes of drugs currently in trial?
Yeah, I don't mind picking up that one. I think that there's been some really innovative work actually that came out of the Kalin lab around CDK4/6 inhibition combined with VEGF inhibition or HIF2 alpha inhibition. And there are currently early studies that are being conducted with that class of agent. The CDK4/6 inhibitors are already approved for breast cancer and are being investigated heavily across other solid tumor malignancies. So if I had to, they are a new class of targeted therapies that I think are being investigated in RCC. I mean, I think we continue to push on the VEGF pathway, with drugs like XL092 that, Hans mentioned, but I do think that there are other targets that could be explored.
Thank you.
Great. Thank you, Chuck. Appreciate that. We also have, I believe, Dr. Michael Surzan. Are you able to? There he is. Great. Nice to have you here.
I am. It's good to see you all. I'm a medical oncologist up at Dana-Farber, and my question is, any thoughts on how we can reach patients who are able and willing to travel with information about trials that their primary oncologists may not be familiar with?
Oh, very good question. So there are actually individuals that are building apps and building social media platform tools to better connect individuals to trials. The one that I'll highlight is Hala Borno. She's a research investigator at UCSF and is in biotech in Silicon Valley and is actually launching sort of I forget the name of her company, but it's basically a phone app tool that can help directly connect patients to trials. And I think going beyond sort of just like what clinicaltrials.gov does, but actually having sort of a nice interface for connecting individuals. So I think that those tools are being developed. I think we as a research community need to like get on the bandwagon, promote them, like help support them, help fund them, because I think it's critically important.
Yeah, I actually totally agree. I think social media is going to be key here. And actually, let me give you a shout out to actually to KidneyCAN and all the, quite frankly, people and patients involved and hurt by kidney cancer who are on social media, who are sharing their time, who are doing all these different things to actually build this network. I mean, if you think about smart patients, to be honest with you, that was my first experience that was eye-opening to me about what good advocacy can do and good advice can do. The first time I saw these patients was when I was in Hopkins, and they came with this little smart patients thing. And when they came into my office with a smart patient thing, I was like, okay, I don't need to explain to you anything anymore. Just let me know what you want to talk about. So it's really fascinating, to be honest with you, what this community has done and what they can do. The question is, how do you get the first patient who's just diagnosed, is shell-shocked, and doesn't know what to do, and they just put kidney cancer into Google, right? Like how do we capture these patients? What's the funnel? That to me is roughly where we need to capture them. Once they are on the journey, they get really smart, educated, they know everything. That's not the problem anymore. I think it's really important to capture them early if possible.
Thank you both.
Great. Thank you, Dr. Hammers. Thank you, Dr. McKay, on those. I'm getting another couple of sets of questions around for the rare subtype community. In general, can you just give some sort of basic approaches for folks that might be out there from that group?
Yeah, I don't mind tackling that. So I think, whenever I mean, for one, I think there's a lot of potential opportunities to tap into clinical trials in this context. Like if we look into the NCCN guidelines, the number one strategy that's preferred strategy for patients with non-clear cell histology is a clinical trial. And I think ensuring and raising awareness about that to clinicians, that these rare subtypes, I think really important for them to be seen at an NCI designated cancer center where they can really have access to, trials and other sort of resources. And I think making patients aware of that as well too. I think the non-clear cell histologies is definitely, again, a place where I'm doing, genomic sequencing, trying to really understand the tumor. There may be situations where those cases need to undergo second pathology review to really confirm the diagnosis, and really try to understand, sometimes a lot of subsets are just thrown into the bucket of unclassified and really trying to tease out, what's actually going on there. If I see a non-clear cell individual and I genomically profile them and they've got a VHL mutation, they're likely going to behave more like a clear cell. And so that can give instruction on targeting their treatment or tailoring their therapy. So I think the biggest thing is seeking out, a second opinion, seeking out care at an NCI designated cancer center where you could have access to trials that are enrolling non-clear cell patients, seeking out genomic profiling strategies. And sometimes there may be a need for germline genetic testing. Some of the rare histologies are linked to a hereditary form of kidney cancer.
Got it. Hans, did you want to add anything, or we want to go to the next question?
That was perfect.
Good. Good, good, good. I think from the great state of Maine, I think we have Carolyn Sample maybe coming up next. Carolyn, are you there? There she is.
Yes, thank you.
Great advocate right there. Great advocate from the state of Maine.
Right. Thank you, all of you, for arranging this and for giving your time to help us understand where we are and where we're going. You have touched on this, my question, a little bit, but perhaps you could elaborate. I'm an IL-2 complete responder, and I wondered whether there's any new developments in interleukin type treatments or combinations. And I know, Hans, particularly, you did mention a little bit.
Yeah, it's I know we kind of like start the era nowadays of effective therapy with the tyrosine kinase inhibitors, but as you experience probably even before then, IL-2 was available. The problem with IL-2 is even in the high days of interleukin-2, it was only available to, I don't know, single-digit % of patients with kidney cancer, 4% of patients or so. You had to meet certain criteria, not many centers did it. And as you experienced, it's quite torturous to be in an intensive care unit and gain 20 pounds of weight and have multi-organ failure. So, and I get paged every 8 hours, you know what I mean? So we still have it actually as a treatment modality here at UT Southwestern, but it's clearly has decreased in the amount of times that we offer it to patients. So, as I said, the problem really is how do we get to a better interleukin-2? We tried low dose, it doesn't really work well. The bempegaldesleukin, the pegylated form, is just like a different delivery form. It changes a little bit the pharmacokinetics. It's the same IL-2 molecule that didn't pan out. It was a big no-no in drug development. And so my hope personally is that we will see much more single agent combination efficacy with the synthetic interleukins. The problem with interleukin is two things you really don't want to have. One is that the blood vessels open up and you swell up like a balloon. And the other one is that you suppress, that you foster cells that actually suppress the immune system, such as T regulatory cells. And so there are some interesting tricks that they can do with protein engineering, some beautiful science, basic science that has led to this, is being employed to just make better molecules. And so hopefully that's going to be the trick.
Thank you.
Great. Thank you, Caroline. Appreciate it. We have another question coming in from Rebecca. Rebecca, I'm not sure what state you're hailing from, but thank you for joining us.
Thank you, Brian. I'm joining from the great state of Texas. And so thank you, Dr. Hammers, Dr. McKay. Appreciate your time. My question is, when you complete a clinical trial, do you have to wait a certain amount of time before you begin a new trial? So yes, before you begin a new trial, so it depends. So typically there is a washout period. Most trials have like 2 to 4 weeks washout period if you want to begin a new clinical trial. For standard of care drugs, you don't have to wait. You can just start the next day, so to say, you get the pills or prescriptions or whatever is happening. But yeah, for clinical trials, it's typically a washout period, 2 to 4 weeks.
Yeah. I think the other thing to kind of piggyback is if you're at a transition point in your treatment, if you're on a therapy and there's a point in time where whether for, disease progression or some reason you're transitioning, those are kind of perfect opportunities to kind of seek out, okay, what should I do next? What trial should I go on? Don't start on that next therapy. If you go ahead and embark on that next therapy and say, oh, I'm just going to go ahead and get started and then let me explore trials, that's I would say, yeah. Hans, you want to say something?
You speak from my heart, Raina. So first of all, when you progress and something happens, it's a perfect time to ask around, get a second opinion. Again, your oncologist should not have a problem with this. My patients get second opinions. I give second opinions. It's no problem. It's because no site, for example, has every clinical trial. Somebody may be excited about something or something else. So it's really, that's a perfect time to do it, number one. And number two is the worst is if the patient got a prescription for a pill, took the pill, 2 days later sees me and I'm like, oh, well, you just started the therapy. I can't put you on a clinical trial anymore because you took two pills of these things and you're, like the technical aspects of the clinical trial just don't allow that. So it's if you want to have another opinion at that point, it's so important not to start a therapy. Get it quick. Typically, that works quite well.
Yeah.
Thank you.
Good. Thank you, Rebecca. Appreciate
Thank
it.
you.
All right, folks. Well, we still have a number of questions that have been asked that are in the chat that I'm scribbling notes here, and I'm trying to figure out what's the best way to approach this. And then I've got a couple others that were sent in via email, but I'm going to give you all, I think in Jeopardy, they say potpourri. Here we go. You've got bone metastasis, translocation, talking about the app, Raina, that you explained earlier, what's going on in cell therapy, and can you contrast any of the Checkmate 214 and the Cosmic 313? There you go. You pick your choice.
You go ahead, Raina. You go ahead. I pick
Well,
up the
I
rest.
guess to temper the data around. Wait, what was the last one? Now I'm forgetting the questions. Can
There
you
was
contrast Checkmate 214 and which one?
Cosmic 313.
Yeah. So first I will say is while we want to sit and like nitpick these trials and kind of compare the numbers and everything, the 313 population was a totally different patient population than 214. So the 313 population really did not enroll any favorable risk patients. 100% of the patients that enrolled on that trial had intermediate or porous disease. 35% of them still had not undergone a nephrectomy, still had a large tumor in their kidney. There was a very low number of patients that had sarcomatoid RCC, and we know that actually patients that receive Nivo/Ipi that have sarcomatoid features do quite well. So I think it was a very unique and different trial population than 214. So I don't think we can look at the numbers and kind of compare them head to head. But nonetheless, I agree with Hans that the toxicity was it's something to contend with, and I certainly think that the liver toxicity resulted in kind of people running into trouble, and the way that the trial was designed kind of mandated that people had to undergo dose reductions. They had to discontinue the ipilimumab just as soon as there was anything that kind of went wrong. And so I think it resulted in a lot of individuals getting a lot less Cabo than was intended and a lot less Ipi than was intended. And I think the long-term question is going to be, is that going to negatively impact the overall survival signal? What does that even look like? Because I don't think PFS is going to be sufficient. I think we need to be moving forward with regimens that improve survival, especially in the frontline setting, and that optimize quality of life.
Got it. Hans, did you want to take a crack at one, or do you want me to keep going with some other ones?
Give me the first two. I forgot already what the first two were. The first two, and I go from there.
Just a general question about bone metastases, and another one about translocation, and if there's any maybe news in that front.
Okay, so on bone metastases, I would say people might be a little bit split about it. To be honest with you, I don't care where the cancer is when I choose the therapy for most of the time. Bone is one of them. You can have beautiful immunotherapy response. In fact, you can see sclerosis of the bone, like new bone formation if they respond to it. But bone is a problem in general terms, meaning if you have bone-based disease, that's hard to control. TKIs tend to be a little bit less effective there in long-term control, so to say, than soft tissue lesions. So it's a challenging disease. But if you respond to immunotherapy, it doesn't matter where the cancer was, in my opinion. Translocation, renal cell.
Before you answer the
Yes.
next one, I have to give a plug for the Radical study.
Yes, please, absolutely, do it.
That is looking at radium-223, which is a liquid radiopharmaceutical, basically targets the bone microenvironment. It's combined with cabozantinib. I think there's also opportunity for other radioligands to be investigated in this context, but it really is an unmet need. And I think the other issue is for people that have bone-only metastases. They have trouble getting on clinical trials. They don't have measurable disease. So this is a trial designed specifically for individuals with bone mets.
This is the time round, Dr. Hammers. You only have one. We're coming down the last couple of minutes. So you were going to say something, I think, about translocation. Maybe.
Yeah, translocation is a real challenge, to be honest with you. Often it's younger patients. So, it's also actually more common, quite frankly, in the pediatric population. It's a real challenge. Typically doesn't respond too well to immunotherapy. TKIs is really the mainstay. Again, we try immunotherapy, etc. The clinical trials ongoing actually in the pediatric population with that, but it's a real challenge. So that I think is a disease where we really have to understand much better how to target that particular etiology of cancer. It's an unusual cancer.
Thank you. Thank you. More research is needed. So one question here from Anne. Do you think future treatments will focus more on quality of life while keeping efficacy, or will they be a better understanding of drug breaks and customizing dosage? Who wants to take that one?
Yeah, go ahead, Rana.
No, I mean, I think it's a incredibly important topic. I mean, I think it's actually particularly relevant as we think about, moving into triple therapies. Like, is this the right dose? And so I think there are studies that are being designed on actually being able to discontinue the immunotherapy component after a certain period of time. But I think we need to better, as a field, design studies where we can kind of maintain efficacy, but also, limit the toxicity, limiting the negative impact on quality of life. I think, Hans, you and others have worked very closely on this concept of treatment-free survival. And what does that even look like for patients where they're off therapy and potentially without toxicity? And how can we actually try to maximize that outcome? And I think integrating that outcome into a lot of the studies that are ongoing is going to be really important.
Yeah, and I think it also depends on really what's the intent when you do a certain therapy. So if you're doing something with curative intent, then it's a different story, right? Like as before, if somebody's on high dose IL-2, right? I mean, to be honest with you, there's no quality of life if you're like in the ICU and gain 20 pounds. But if you cure someone, they can work. So the same if you, let's say, do CAR T-cell therapy and were more toxic, hospital administer, hospitalizations, etc. And then the quality of life is pretty bad. But the truth is, you get your shot at potentially getting a cure. Same with immune checkpoint inhibitors. You can get all these inflammatory syndromes, but you roll your dice at potentially getting a very deep, very durable response. So it's a different scenario than, okay, immunotherapy doesn't work. Now it's about keeping you for alive for as long as possible, but I cannot cure you anymore. I think then really quality of life becomes even more important in that space, because patients go from one TKI to another TKI, etc. And I think something like a HIF-2 inhibitor, for example, is almost like the perfect drug for the palliative space, where patients sometimes have very few side effects but can have significant activity.
Great. Well, thank you both. We've run out of time. I mean, the hour flies by. A lot of good questions, a lot of good information. Really want to say thank you, Dr. McKay, Dr. Hammers. Really appreciate you taking the time out of your day to explain this on terms that we all can understand from the community here. So thank you. Also want to thank our sponsors, Eisai, Exelixis, Genentech, and Merck. Couldn't have done it without you. For those who are going to be watching round 2, our next town hall is going to be April 25th. At 6 p.m. The theme's going to be making the most of more time, and it's going to be stories of long-term survivorship. So April 25th, mark your calendar, 6 p.m. Eastern. But more importantly, we're going to have our spring advocacy days coming up here real soon. We're going to be going to doing a hybrid event where some of us are going to go to DC and knock on doors, and others are going to do it virtually. And the bigger grassroots army we have, the louder our voices. So if you could consider signing up with us, you could contribute to help get more research dollars for kidney cancer research. So appreciate that help. Also, there's a social community gathering. I think it's going to be thrown in the chat right now. You can go over there and hang out and talk to some other folks if you need some information or just want to share your story. Come on over to the community social. But again, Dr. McKay, Dr. Hammers, really appreciate it. Makes a big difference to the community. Thank you so much.
Of course, our pleasure.
It's been a pleasure.
Happy New Year.
Happy New Year. Great job, Raina.
You as well. That was awesome. Brian, that was